This episode is sponsored by Lilly, a medicine company turning science into healing to make life better for people around the world. Lilly has been pioneering life changing discoveries for nearly 150 years, and today, its medicines help more than 51 million people across the globe. Harnessing the power of biotechnology, chemistry, and genetic medicine, Lilly scientists are urgently advancing new discoveries to solve some of the world's most significant health challenges, including transforming the most difficult to treat cancers into manageable diseases. Hi, everyone. My name is Samira Daswani, and I am the host of the podcast, The Patient from Hell. I have an incredibly special guest with us today. I've known Kimary now almost a year and a half. She's one of those women who I am truly a fangirl of, by the way. So I feel a tiny bit intimidated today, but also I'm incredibly excited to have her on this episode. Kimary, thank you for taking the time and joining us today.
Thank you for having me on your podcast, Samira. I have to say I'm really happy you invited me because this is yet another one of these huge topics in oncology that I'm really passionate about and frankly could talk forever about. And I'm really passionate about wanting to teach anyone who will listen, quite frankly, about the topic of cancer biomarkers. So
All right, you lied right into it. So maybe we start with just that. So you're known as the biomarker navigator. Can you tell us how you got to having that name?
well, it's a self-given title, actually, and part of it is because I'm actually trying to kind of coin the term, if you will, biomarker navigation. I think a lot of us have heard about patient navigation and types of patient navigation, and it's becoming more recognized and even reimbursed most recently. But I really feel like there's a niche area of patient navigation that for which there's still a really huge unmet need, and that is around the area of biomarkers and cancer biomarkers and helping patients make sure they get this really important testing.
Uh, Kimberly, I think we need to define biomarker. I think you hinted at that even while we're talking briefly about the episode. So maybe we go straight in. Can you just, what is a biomarker?
A biomarker, and I'll do this in oncology speak. A biomarker is something that can be measured in the body, either in the tumor or in the blood, a molecule. And in oncology, we're mostly talking about genes or proteins that can tell you, how the disease is going to behave. And in that case, we're talking about a prognostic biomarker. So, what kind of course is the disease going to take, regardless of what type of treatment you get? And then there are predictive biomarkers, and those are the ones that kind of help inform treatment decision making. So, if you have a certain biomarker, you should get a certain drug because we know you're going to do better on it. And this is the class of predictive biomarkers that relate to drug prescriptions.
Okay. We're going to do this a lot. I apologize in advance to you and to everybody listening to this episode or watching this episode. I believe that this will be one of our more technical episodes. So I may pause, Kimberly, and ask you for definitions, just because we're entering a part of oncology, and please correct me if I'm wrong on this, that is very fast moving. Our understanding is constantly evolving, and it is very dependent on the biology of cancer.
Yes,
Fair assessment?
yes, it is. Yeah.
Okay, so the reason I say that is I'm in this specific episode, we'll ask for a little bit of like bio 101 as well. So
Mhm.
I'm going to roll back all the way to the top of what you said. I heard you say uh, in the world of cancer biomarkers, there are genes and proteins. Can you explain genes versus proteins? Just very, very briefly, so we all have a sort of similar understanding of where we are.
Absolutely. Yeah. So, and I do actually, I have developed material to teach this directly to patients too, because I do think it's really important to make this distinction between a gene and a protein, because both of them can be biomarkers. So a gene is really DNA. DNA is the blueprint. I have an analogy where I think of like the DNA is like the architectural blueprint to build something. DNA is actually, it codes, it gives the instructions to build a protein. So DNA gets transcribed into RNA, which gives instructions for specific amino acids to link together to create a protein. And why it's important to make that distinction is because these a gene can be a biomarker and a protein can be a biomarker, but they're tested in different ways.
Hmm.
So when we talk about testing a gene, biomarker testing that's gene based versus protein based, they use um, different material and different testing platforms.
Super helpful. So I'm gonna before we sort of switch into how we use biomarkers, I'd love to spend a few more minutes on this. Um, in the world of testing, can you help explain genetic testing versus biomarker testing?
Yes, that's a really important question, and it's one that I find trips up a lot of people. And I think that's partly because in the clinic, it's referred to as genetic testing.
Yes.
And and I think that's sort of a result of there being genetic counselors to talk to patients about genetic testing. But genetic sounds a lot like gene. And when we talk about genes and gene mutations, they can be of different types. So genetic testing, as it's called in the clinic, is really looking at germline alterations in DNA. And what does that mean? Germline refers to the origin of the DNA being from germ cells. You get egg from mom, sperm from dad. Those are germ cell lineages. And so when we talk about genetic testing or germline mutation testing, we're really looking at what is an inherited gene alteration, a mutation, for example, that you got from your parents. And it's in all of your DNA, in all of your cells, in your entire body. It's not just in your tumor. When we talk about somatic mutation testing, we're looking at something that is in the tumor and not necessarily in your germline. It's not in the germline, actually. So when you have tumor biomarker testing, you're looking at somatic mutations mostly, but some of those somatic mutations could actually be germline mutations. So you may have inherited them. They could be found in all of your DNA. And one thing I'm seeing a lot and hearing a lot and reading a lot about these days is that germline testing, this hereditary testing, is underutilized. I've seen cases where a patient has shown me their biomarker test report that shows somatic mutations. And some of these genes that are mutated are the same genes that can be germline mutated. So I'll use an example. I had a breast cancer patient. She had a BRCA1 mutation in her biomarker test report. And the first thing I asked myself was, is this a germline inherited mutation? Or is this just in her tumor? And when I dug deeper into her medical records, I did realize that they did do germline testing on her, and it was not a germline mutation, it was only in her tumor. And the importance of that was, that was sort of a sigh of relief because it meant that her daughter, her sisters, her grandchildren even didn't have to have testing for that gene necessarily based on her history anyway. So that's the difference. The somatic mutation is in the tumor. Germline mutation is in all of your cells, including your tumor cells.
Got it. Can I summarize it in maybe a slightly different way, and can you correct me if I get the summary wrong? Um, if I understand germline versus somatic, germline I am born with, somatic I can get at any point in my life.
That's true.
Is that a fair way to summarize it?
Yes, it is.
Okay.
Definitely.
So sounds like germline testing. I essentially have no. Uh, I'm okay. I'm gonna say something, and then you may have to correct me. I have no control, like the biology of it. There's no. We don't have any sort of control over it. It just exists. You're born. It's there.
Hmm.
Somatic mutations can keep changing during the course of a cancer experience.
That's true.
Okay.
But just because you have the germline mutation doesn't necessarily mean it's going to manifest as cancer. These are really, what we call predisposition genes. So you have a much higher chance of developing cancer. And it may involve having what we call a second hit, where in addition to having that germline mutation in your DNA, you also have another assault to your DNA, which could be in the form of a somatic mutation or some environmental exposure or something that can also cause the tumor to happen in the first place.
Got it. Got it. Okay. One more question for you, and then I would love to go into an example. The question is genetic testing versus genomic testing. What's the difference? Is there one? How like does it matter?
Yeah. Well, I think the easiest way to answer that question is when we talk about, and if I understand what you mean by genetic testing to be germline testing, you can do that using a saliva sample or a blood sample.
Hmm.
It's not a tumor test. In fact, to truly know germline, you need normal tissue to test, not the tumor tissue. So that's one big difference is, it can be a simple blood test, it can be a saliva test. Sometimes they also, if it's a tumor-based testing, it's possible to do somatic and germline testing at this, with the same sample. But usually they do that by getting some of the normal tissue that's around the tumor tissue to use as the normal comparison. So the test itself is the same thing. It's sequencing DNA, what we
Yeah.
call next generation sequencing or NGS, which sequences the DNA. That test is actually the same. It's more the specimen is different. We're looking at normal cells versus just the tumor cells.
Got it. Okay. Can I? I'm gonna attempt one more summarization, and then you can tell me if I'm right or wrong. Uh, so the way we test to get to a mutation, any mutation, at the genetic level is next generation sequencing. Essentially, we're trying to figure out what the series of codes are, like the alphabet.
Yes,
And the sample we are running that test on is either normal tissue, i.e., fully healthy normal tissue, or it's the cancer tissue.
correct. Yes,
And depending on which sample we're running the test on, we get different information.
true. Yes. And I think the example I tried to bring up before, which is where it confuses a little bit, is that sometimes on the tumor sample, you can find a mutation in a gene that is one of these cancer predisposition genes that you often find as a germline mutation. So good examples of that are like BRCA1, BRCA2, TP53, so these tumor suppressor genes, as we call them. And it's important to know,
Yeah.
and I'm finding this ignored a lot in practice, but it's important to know whether those mutations that are in those genes in the tumor are not also germline and in all of the cells. Because if it ends up being a germline mutation, then the family should be tested. It's called cascade testing. And I think what I'm hearing a lot about and seeing is that patients are told, my family doesn't need to be tested because we don't have a huge family history of cancer. And my answer to that is, well, how many of us really know what great grandma actually died of? How much of it was unspoken within family oral history? Um, and I think that the time is sort of past where we should be relying solely on this sort of oral report of family history to kick in gene testing. The other really important point I want to make is that, and this comes from a case I just had recently, where a patient has a BRCA2 mutation, and it was properly found, and she had genetic counseling, and she followed up, and she has daughters, and her daughters were tested. But I asked, "What about your sons?"
Oh,
And no one told her. Like, she didn't. It wasn't explained to her that this isn't just a breast cancer gene. That this your sons can carry this and pass it along as well. Puts them at risk for certain other types of tumors, and it puts any children that they have at risk as well. So I think that's another really important thing to emphasize, is it's not sex specific. It puts everyone at risk no matter what.
super, super fascinating. I actually, when you said that about the gender thing, there's also a lot of bias, right? There's a lot of unconscious bias that plays out, especially in breast cancer.
I think so.
So that's actually, I had not thought of it that way. I did want to, I did want to use one more example, and I'm probably going to do it really badly, and I suspect some people are not going to be very happy with me with doing this example. But I think it's an important one because it comes back to what I was trying to draw out, where in genetic testing, at germline, true germline, i.e., I am born with it, can't really change it. And then there is this like acquired mutation. It happens at some point in the duration of your life, exposure to toxins. I want to go to lung cancer for a minute
Mhm.
because lung cancer is, from a scientific lens, I think really fascinating because there's so much biomarker testing happening now, and so many treatments are tied to the results of next generation sequencing or NGS. That one I think is just like a fascinating, like nerdy moment for me. But like, it's pretty interesting. But more important than that, though, for me is in a cancer type where we know that exposure to certain types of compounds, asbestos being one of them, and or a action, i.e. smoking, does result in an increased risk of cancer. I'm sort of curious as to how you think about uh, biomarker testing with smoking, without smoking, asbestos exposure, no asbestos exposure. Where does germline testing kick in? Where does somatic testing kick in? So just a little bit more in a place where, in a type of cancer where we know from the data we have that there is potential for an acquired mutation.
Yeah, I like to. I say lung cancer is currently the king of biomarkers. There are more validated biomarkers in lung cancer right now than any other solid tumor type. I think breast maybe comes in second. But right now there are 12 different biomarkers per NCCN guidelines, that every patient with non-small cell lung cancer, particularly adenocarcinoma, non-small lung cancer, should be tested for. Um, and yet we know that 100% of them are not being tested for that, but that's another story. Um, but your point about smokers versus never smokers, or other exposures, is really interesting because there is a different sort of genetics, or a molecular signature, if you will, in tumors from smokers versus never smokers. And we're now in this era of immunotherapy in lung cancer. And it turns out that those signatures have implications for who's going to do better on immunotherapy versus who's not. But let me back up a little bit because lung cancer is sort of an area I've spent a lot of my career working in. I was actually really fortunate to work on the very first targeted therapy for ALK translocated lung cancer when I was at
Whoa.
Pfizer, and that was the drug crizotinib or Xalkori, and that's really when I got first exposed to and really interested in biomarkers, by the way. Um, but you know, the 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 number of, I guess, let's say, oncogene driver mutations, and we should define what that means too. Some of the genes that are mutated that we're talking about, these somatic mutations, some of them are in genes that kind of are like the gas pedal for driving the cancer growth and spread. And some genes are suppressors that kind of put on the brakes to a tumor being able to thrive and divide and grow and spread. Most of the biomarkers that we have right now, and we're talking lung cancer, but it's pretty true for other tumor types as well, are in these driver or for these driver mutations. The drugs that we have to target these driver mutations are to stop an overactive process. So if an oncogene is driving, putting the gas on the tumor, the drugs that we have are putting the brakes on that same
Mm.
tumor. So if we have an ALK translocation and we have a
Yeah.
drug that is an anti-ALK medicine, it's basically stopping that ALK gene translocation from giving power to the tumor and energy to help it sort of thrive.
Mm.
So these oncogene drivers tend to be more prevalent in tumors in patients who are never smokers. So and when this all first started coming to fore, you know, we didn't really know because a lot of the studies that were done in cancer populations, it's a very highly selected denominator of patients, right? So when you have young Asian never smoking women, the prevalence of an EGFR or an ALK mutation, doubles, right?
Whoa.
But if you just take an all-comer population,
Yeah.
prevalence, for example, of ALK is only 3 to 5%. Um,
Huh.
So, in the beginning days of all this, biomarker testing was sort of, we talked about bias before. Biomarker testing was pretty biased in the beginning towards, oh, we really only need to screen young never smoker women, for EGFR mutation or ALK mutation because they tend to have it more. That's true, but it doesn't mean that if you're, an older male, you know, even smoker, you may not also have the same mutation. So that's gotten a lot better. And I think guidelines have helped with that as well.
Oh.
But at this point, I'm not even sure I've answered your question at all.
I was, I was gonna make a funny little joke. I was gonna make a funny little joke, by the way. So I'm a bioengineer from MIT who studied molecular biology, and I can barely understand enough about biomarkers to ask a question. And I honestly, Kimary, feel horrible for any patient who's having to navigate it today because I mean, I skew really privileged. I have a science background. I understand papers, and I can like barely sort of kind of maybe ask a question, let alone forget about understanding it and making an informed decision. And I think the reason I'm going there right now at this point in the conversation is because we went 2 feet into lung cancer, right? And there are 12 biomarkers based on the demographic of the population, based on the type of mutation. And I don't think you said this, but I'm going to put words in your mouth for a second, and you can correct me if I'm wrong. Is depending on your test, your treatment's different.
Yes.
And that's the reason I think it matters that your work is, one, super important, and two, I think it's super important for patients and family members to understand what we're talking about, because treatment decisions are actually being made off of the results of these tests. And if they're not being made, they should be made. And I just made a should statement, partly because guidelines have changed and actually require testing, because we now do have a lot of treatments that are contingent on the results of these tests.
Yeah.
And I would love for you to sort of like explain that a little bit, because I think we need to like put a fine point on that, because in the absence of that, I'm a nerd. I'm happy to like nerd out on like oncogenes and drivers. But I think it's also, I think I want to go back to where you set up the conversation, which was prognostic versus predictive. And somewhere in the pathway, we're going from your family should be tested to, hey, by the way, your treatment plan is being determined by the result of this test.
Yeah.
So I'd love for you to talk about that, if that's
Yeah.
okay.
It's funny because as you were describing that, I just popped into my mind that like I sometimes have described to people that what I do with as a biomarker navigator is like try to help people avoid just going on chemo. Like my goal is to help you get a targeted therapy or
Mm-hmm.
immunotherapy if it's appropriate. And
Yeah.
because I think we are at an age in particularly lung cancer, but others as well,
Yeah.
where we have the privilege of being able to offer a targeted therapy as a first line option for metastatic therapy.
Yep.
And what we're finding still, and even though lung cancer is sort of the poster child and the king of biomarkers, we're still finding that. And there was a really great paper on this recently, where only about 60% of lung cancer patients are benefiting from the targeted therapy.
Yeah.
And there's multifactorial reasons why that's happening. Back in the day, it used to be what we call the tissue issue, where there wasn't enough lung cancer tissue to do all the tests, or it got used up, or if a
Yeah.
patient enrolled on a clinical trial that required that testing, there was no more tissue left. We've gotten better at that. Now we know there's so many tests that need to be done that we have to take, not just a fine needle aspirate, not a cytology specimen. We need to get a good core needle biopsy. That goes a long way. And now we're also in this age where we have blood-based testing, which we can talk about later. But so that's not the excuse anymore. And yet it still kind of is.
Yeah.
And the other big thing, the big issue in getting these targeted therapies up front to patients as their first option of treatment is there's a really long lag in the turnaround time between acquiring the tissue, and by that I mean either getting the biopsy or finding the biopsy material wherever it lives out there in the community, getting that sent to a testing lab, the lab performing, is highly sophisticated, laboratory tests that they're performing, but there's also really highly sophisticated analytics after the testing. So we're talking about looking at the genes and comparing them to normal, comparing them to
Yeah.
normal variants. So what is really a mutation that has a pathologic significance that's actionable, as we call it, with drug therapy. So that can take from 10 days to, I've heard horror stories of 8 weeks. And that's the problem right now. When you're a metastatic lung cancer patient who presents at the clinic with brain mets, liver mets, and you need therapy, you really don't have 10 days to 4 weeks to wait. And I just recently wrote an article about this, and I call it life expectancy spent waiting. I like to remind clinicians, especially when they push back on a timely biomarker testing, that 2 week wait time can represent 20% of a patient's life expectancy at that point in time. And that is getting used up in this wait time. So what happens in a lot of cases is, because of this long turnaround time, a physician will choose to put a patient on chemotherapy just to get something going, while we wait for the test result to come back. And if the result comes back and it's a driver mutation like an EGFR or something else, you would think you should switch right away onto that targeted therapy, but sometimes that doesn't happen, because if a patient's doing okay on chemo, the physician will keep them on the chemo. And then
Yeah.
you're basically rendering that targeted first line therapy as a second line therapy. The other issue is that sometimes it's not safe to switch from the chemotherapy right to the targeted therapy, and you need a washout period in between, which also is eating up precious, you know,
Mhm.
remaining life. So it's very complicated. I don't envy lung thoracic oncologists, because they have to make these really critical decisions on a daily basis, and there's a lot for them to keep up with. So
I have so many questions. So maybe I can give a tiny bit of context. So we have two of our advisors are thoracic oncologists. So we've been spending a little bit of time in the lung cancer space recently, and I know you know this, but we haven't launched the platform yet, so not everybody knows this. But we build maps for the full cancer experience across different types of cancer, and one of the ones that we've been working on is a lung cancer map. And the reason I share that is the precise thing you just spoke about, the last couple of minutes of what you just spoke about, which is, if you are a clinician and you have a patient who shows up with metastatic non-small cell lung cancer and they are presenting with symptoms, and you know that next generation sequencing is going to take 10 days to 8 weeks, the odds are you're going to start them on chemo. And even if the clinician knows that they should do biomarker testing, which is a whole thing we should be talking about because that's not always true, but let's say the clinician knows that they should do biomarker testing, today's system doesn't actually enable that to be a real choice.
Mhm. Mhm.
And then you didn't say this, but I'm just going to put this out there is, let's say the biomarker testing now comes back, patients on chemo, biomarker testing comes back. I heard you say two things. One was you may just wait to put them on the targeted treatment. And sometimes it's not safe. Sometimes you do need the washout period.
Mhm.
And I'd offer a third in there, which is the patient side. And sometimes as a patient, you may know you only have so much time. And maybe you don't want to take the risk. And
Right.
the reality is we're operating in that window. We actually, and correct me if I'm wrong, Kimmy, but there actually is not that much data, right? The data, the body of data that is patient started chemo, now you've switched within first line, is my understanding of it, outside in our understanding, is pretty limited. So it really comes down now to the art of medicine meets the preference of the patient.
Yeah. Yeah.
And going back to like what I said a couple of minutes ago is, as a patient, I barely understand what a mutation is, let alone like the decision between targeted treatment meets chemo meets immunotherapy meets how that affects my overall life. Now, if there isn't data, how in the world will I come to any informed opinion or decision?
Yeah. And I think you touched upon something really important there, and that is the patient's, you know, preference has to be factored into that. The last lung cancer patient that I helped, was tired of waiting around. I mean, he was waiting for appointments to see an oncologist, and he also had brain mets, and the choice had to be made whether to do whole brain radiation, and they were ready to do that, but he had not even seen an oncologist yet. And then there's me saying, what about biomarker testing, because he
Oh,
probably has an EGFR mutation, and there are drugs that can cross the blood-brain barrier, and maybe we don't need to do, so it's really, really complicated. But in that case, the patient said, I need to do something. I need to take action. And so that, I think that kind of helped the whole team, including myself as someone trying to help him, sort of just draw a line in the sand and say, okay, we're going to do this. But the other thing I learned during that experience, and again, like, you hear all these things and you read all these things, but in my case, like when I actually meet it in reality, it becomes like little N of one data points for me. I think what really needs to happen, and I'm going to advocate about this until I'm blue in the face probably, is that there needs to be, especially in lung cancer, what I call reflex testing. So why should we wait
Yeah.
for, if a patient has to wait 12 days to see an oncologist? That's
Yeah.
just 12 days of lost time. A pathologist is the first person to see the tissue, to see the quality of the tissue, to know if there's enough of it for testing, to kind of guess whether it's going to yield a result or not, to figure out how many tests we can get from that sample. They should be the ones, I feel, ordering the biomarker testing, such that by the time, if a patient has waited 2 weeks to see an oncologist, maybe
Yeah.
the biomarker report is already in the oncologist's hands when they see them. It literally shaves 2 weeks off of the inevitable wait time and
Mm,
gives a better chance of getting a targeted therapy right up front
mm,
versus starting that chemo and then we're kind of
mm.
stuck in that trajectory, right or wrong. But I think there are some simple fixes from an operational, like a clinic operational
Yeah.
perspective, that
Yeah.
we could incorporate to help this lag time situation.
Uh, that's okay. I have so many. I'm gonna define reflex testing, and then I have a question for you. So just to be clear on reflex testing, because I don't think we defined it, is essentially you're ordering it effectively at the same time. You're essentially not sequencing the ordering of testing. You're basically saying we're gonna basically order everything now.
Yeah, well, I think it's more of this is a non-small cell adenocarcinoma patient. We know there are 12 biomarkers that need to be tested. I don't really need to ask the oncologist what they want tested because this is what the guidelines say. And the guidelines go so far as to even say that, gene panel testing should be done. So it's a check a box, send it off for NGS. And, this artificial wait time is, I think it just needs to go away, frankly. Um,
Something you just said that I think is actually really, really important because I don't think it's just about the reflex test. It's about who is ordering the test, right?
exactly.
Because I think you said that, and I think that's actually a really, really, really important point because, and I don't know if most of our listeners will sort of follow this. Is today, and correct me if I'm wrong, Kimary, but today the oncologist is the primary individual who's ordering the test,
Yes.
right? So the
Yes.
oncologist is waiting for the results of biopsy to come back, is then doing the analysis you're talking about, which is what type of cancer are we dealing with? Is it non-small cell, small cell, adenocarcinoma, large, I'm forgetting what the large cell, other types of non-small cell lung cancer? And then based on that, they're then ordering the NGS test.
Yeah.
What I'm hearing you say is, hey, there is a gap between the pathologist finishing the biopsy and the oncologist reviewing the results of the biopsy. There is a time lag. And if the pathologist could just order the test, that time lag effectively drops away. Did
Yeah.
I hear that right?
You did. I'll just make one tiny correction to it. That is, it's not only the time lag between the diagnosis being final, like the final pathologic diagnosis, and the oncologist seeing that. What's happening now is their patients actually have to wait to be seen, to have a clinic appointment with the oncologist. So it's like they won't even order the test in some cases until they've eyeballed the patient, and
Yes.
taken a medical history and understand it. And I went this patient that I tried to help. I'll get really detailed here because I think this is important, and it highlights the type of work that I do on behalf of a patient. I get really detailed. I get into their pathology report, not just the biomarker report. I read the pathology report. And in this particular case, I read a notation by the pathologist that said, this was a bone biopsy, which is not the best type of tissue to send out for NGS because it needs some chemical processing before you send it out. But the pathologist made a notation saying there were a small, and I won't use his technical language, but he basically said that there weren't enough tumor cells in the sample and that gene testing was likely going to fail and
Oh
that they
wow.
would try to do PDL1, protein testing, which is a different test. It's an IHC test. I read that and I immediately got alarmed and I said, we need to order a blood-based test, which we haven't talked about yet.
Yeah.
And so I put in notes at this point, the patient had only seen a radiation oncologist. He
Oh
was
my god.
waiting for an oncology appointment. So I alerted the radiation oncologist and I said, look, we need biomarker testing. It's not my department. I don't order it. It's a good idea though,
Yeah.
but it's not his oncologist will have to order that. And so again, put in notes to the staff and you get a call back from an oncology nurse and says, well, it's the oncologist who orders that and he hasn't seen the oncologist yet. I'm like, I get it, but can we just, you know, like fast forward this a little bit and can the oncologist please order a blood-based test because of this notation? In the end, we were able to move it up by only 3 days. The oncologist did do it before he saw the patient, but it took so much time. We only shaved off 3 days in that case. But there's a perfect case where if the pathologist is writing the notation, there aren't going to be enough cells to do NGS, then boom, they should reflexively order a blood-based biomarker test.
Yeah.
In place of that. And that's, I feel that's a perfect example of what needs to happen in the clinic.
You sound incredibly calm. Just in hearing your story, I am so agitated. Just so you know what my emotional temperature. You sound so calm. I just when I hear stories like this, and I think it's partly because I go through versions of this. Except I'm a survivor, and I don't have a 9 month life expect. Well, not that I know of, a life expectancy at this point in time. But what you're describing happens all the time,
Mhm.
all the time. So part of me is really, really annoyed at the system, and the other part of me feels horrible for the oncologist because if you look at their days, they're going back to back, they're burnt out, they barely have time to eat, sleep, drink water.
Mhm.
They're doing, I don't know, truly, truly life saving work, and they have 20 minutes with the patient. So part of me is like super mad at them, and the other part of me is just like, oh my god, I feel so, so sad.
Yeah.
It's just,
Well,
it's
it's
a,
kind of, it's sort of that. This is the way we do it, right? Like they haven't seen the oncologist yet, so they can't order. And it's kind of like, and very sadly in this particular case, this patient from the time tumors were found in his body until his death was only 44 days.
oh,
So do the math, okay?
oh,
A 2 week wait is, a significant portion of his remaining life expectancy. Now, nobody knows that walking in the door, they can say, but I think we have enough clinical experience to know, heavily tumor, heavy metastatic burden, lung
yeah.
cancer, aggressive. I think we need to prioritize these cases. I really
Yeah.
do. But again, everything you said is true. The system is overwhelmed. Everyone is overwhelmed. I mean, it's difficult, but I think I just keep trying to focus on practical solutions. So if practices like that had someone in between, someone like me who read that report and said, hey, this isn't going to work, we got to order this right away, we could have shaved a couple of weeks off of that for that patient. So that's what I'm trying to, demonstrate the need for, is that, it's not only the patients who need navigation, quite frankly, it's
The oncologist.
it's the practices, it's the oncologists themselves, because how can we expect them to keep up with all of this? They're not taught, molecular biology in medical school, and unless they went out of their way to get this education, or they also did a PhD along with their MD. And this is and it's only going to get worse, right? I mean, it the as the more we discover about tumor biology and molecular biology of cancer, this is just going to explode. And so we need to get ahead of this. And that's why I'm doing what I'm doing, because I really think it's going to be like the equivalent of genetic counseling.
Yeah.
We need somatic mutation counselors,
Yeah.
i.e. biomarker navigators, right? To talk to the patient about this. I've had patients who've come to me because they had no one else who would walk through their biomarker report with them.
Yeah.
800 gene, report is not something that an oncologist has time to sit down and talk to about a patient. Instead, they say, there's nothing actionable in here, or, you wouldn't understand it, or I don't even understand half of this stuff. This is what patients are being told by their very own oncologists. And I've had a couple of patients who've called the gene testing companies and said, can you go over this report with me? And they say, no, you have to talk to your oncologist about it. So it's like this runaround, and I find that that's one service I do provide to patients that they're very grateful for, because I believe everyone has the right to understand their own biology. And I always start with education. Like, I want you to understand what this gene is, what's happening with it, and why it's important to your treatment. Um, it's not sort of prescriptive. It's, let me help you understand what's going on in your body, and why it's important to ask these questions to your doctor. So,
Kimmy, I'm looking at the clock, and I think you and I already prefaced this before the podcast started. You and I could talk about this for hours and hours and hours, and we will definitely have you come back on the show and have a much broader discussion on the many different aspects of biomarker testing. In a way to sort of like conclude our conversation from today, what is one thing? So in the absence of having many Kimarys across the world, which would be great, but in the interim, while that's not maybe an option, what is one thing someone who's going through this, a patient or a family member, who may be diagnosed with lung cancer or breast cancer or other kinds of cancers that have biomarker testing as part of the sort of diagnostic or treatment pathway, what is the one thing they might be able to do
that they might be able to do.
to change the course
Yeah.
of their outcome?
Yeah, I think the first thing is just to be aware of it, as a critical, and it's a part of your care that can't be skipped. I The first question I always ask a patient is, have you had biomarker testing? And oftentimes the answer is, I don't know, or they don't know how to find it. And part of the problem is that it's not often uploaded into your my chart, right, or your
We can
patient
do an
portal.
episode on just that. We can do a full episode on just that one, by the way. That moment right there. You and I can talk about just that for a
So
full
that's
hour.
that's the first thing I coach them, is like, it's something you have to ask for. You're going to have to ask someone in the office to scan it and upload it in there for you. Um, and so that's one thing, is just being aware of that up front, and ask. And if it hasn't been done, to ask for it. And that's where it's kind of like, well, what do I know to ask for? What do I don't know anything about this, so how can I ask for something I don't know about? And that's part of the, like, teaching patients to at least know what they don't know, in some ways. Like, you don't have to get really deep into this, but you just need to know that there are these markers that have to be tested in order for you to assure yourself that you're getting minimally standard of care, yet alone the best option for your care.
Thank you for that. I think that's I'm smiling because it's just such an incredible place we end up with the conclusion of the podcast, right? This incredibly complicated, very sciencey, very biology driven universe that we're living in. If there's
Yeah,
one thing you can do is ask your doctor about biomarker testing, and two, make sure you get the report.
yeah. It
Which
sounds simple, but you'd be
is really hard.
surprised.
Oh no,
Yeah,
I would not be surprised. Definitely been there. Don't worry. There's a reason why I can have an hour conversation on genetic reports not being uploaded in the right place in the EMR. Kimary, I have been there so many times.
yeah.
Finding the genetic report from 3 years ago for me is a nightmare. It takes me about 45 minutes of digging, even today. So
That's one
I
thing I do. I do it on behalf of patients. I say, if you're comfortable, give me a username and password. I'll go in and I'll pull it all down for you and collate it and give you a nice summary back. And it's amazing how helpful that is to a patient, because you're going through, I don't know how patients could possibly manage this. Like, I think about as this gets more complex, and again, it's only going to get more and more complex. How can we expect everyone just to stay on top of this? I think that my underlying message here is we need to bring in a whole new profession into the mix, and they need to be scientists, quite honestly.
yeah,
Um,
correct. I agree with that.
and it sort of takes a very special understanding of what the patient needs and what the clinic needs as support in that respect.
On that note, Kimray, I'm with you. They need to be scientists, and we don't have it today. So I fully understand and fully appreciate all the work you do, and that's one of the reasons I'm such a fangirl. One of the many
Thank you
reasons.
so much.
That one in particular. Kimray, I really appreciate taking the time and for teaching us about the world of biomarker testing, why it's important, and what you can very practically do today about it as a patient or a family member. So thank you for coming on this podcast. I'm sure you will be back again, and we will dive even deeper into the topic of biomarker testing.
Thank you, Samira. It's my pleasure, my honor.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The content here is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.